subcategory that's behaving in a different way for reasons that we don't know.
And it's pretty hard to study it, too, because you can imagine if you cut that out, the fraction of tumor DNA, it looks like it's about 20%, and the fraction of normal lymphocytes is 80%.
At the most.
Right,
I
and
would
so,
say 5%.
you know, you're not going to see stuff.
You have
if
to
you're looking at
microdissect
the
it.
DNA, RNA, you have to
Yeah.
get in there and with the scalpel and pluck out all those things. It's really hard to study. We don't know a lot about it.
And there's so few of them, so it's very hard to collect this.
Can you do cell sorting and things like this to isolate the?
Yeah, you probably could. You could sort it by size. Probably could.
But you've got to do that with frozen tumor that you enzyme treat just to get single cell.
I mean, you can aspirate it and put it into a solution, and then you can cell sort it. But you know, you got to then know when a patient with that type of tumor comes in, and you got to be asking for consent and be ready and actually hit. You know, it's like a huge, almost impossible thing to do. All right, so different. I'm finally going to get into how we cut specimens and inking margins and stuff, but I think we're going to make it. So there are 4 different surgeries here. Lumpectomy, where you go in and just shell out the lump. Nobody hardly ever does that anymore, because we have learned that if you don't have a little bit of normal tissue around the tumor, what's called a margin, it's going to recur with a high likelihood. So this is what's called a partial mastectomy, where you take the tumor area and some tissue around it. Modified radical mastectomy is also used, particularly if a patient has more than one focus of disease, or if the tumor is large, or if it's in the center of the breast and you're not expecting to get a good cosmetic result by doing a partial mastectomy. And radical mastectomy includes taking the muscle, and that's very rare to do these days, almost never. All right, so say you receive a specimen, say it's a mastectomy specimen, then it's cut in a very regimented, organized way that can be reconstructed so that we know exactly where things came from, and we can measure the size of things and say where in the breast they were. So say there's a tumor here, you would take, and then you put ink at the bottom against the chest wall, and there is a thin membrane that separates the breast from the chest wall. And you also put ink on all the outer surfaces. So if you have a tumor in there and the tumor reaches the edge, we can actually tell when we look in the microscope. We can see if the tumor reaches the... so that would be a sort of schematic of what you would do with a whole breast.
Who puts the ink? The pathologist?
Pathologist.
The pathologist.
But the surgeon will orient the specimen. So they typically would put, you know, it's like a short stitch at the top and a long stitch at the lateral side. So the pathologist would know exactly what the orientation of the breast is, so that you can put the ink so that you know what's up and down. All right, so here's an example of a mastectomy with the skin still on it. Sometimes the surgeon will save the skin and do a subcutaneous mastectomy, and then all we get is the breast tissue. I'll show you one of those as we go. Now this is going to be flipped over so you see the bottom side of the specimen on the next one. And here's that very thin membrane that separates the breast from the chest wall. And it's a very smooth, glistening membrane that's there. If you have a tumor, even if it's really close to that membrane, if you can move that membrane relative to the tumor, then you know that the margin really is still free, even if it can be just a fraction of a millimeter. So we ink everything before the specimen is cut up next. So here's an example of a skinless mastectomy, and the nipple is marked with a little bit of nipple area. The nipple's not on there anymore, but the nipple area is marked with a yellow ink. And this is blue ink for sky, that's the top. And then soon there's going to be green ink for the brown that's going to go on there. And that black ink goes on the back side against the chest wall. So that's the typical orientation. And you can see the long stitch here, and I think part of a short stitch up there. And then there's a measurement on next. This would be an example of a biopsy, where you just take a little small piece in order to investigate the breast, or if you have a small area of the CIS or a very small invasive tumor, you may not need take any more than that. But we do the inking the same way for a specimen like this too. Next. So here is sort of a schematic of, for a smaller biopsy and how you would take blocks out of it. So you would systematically cut across it like this, and you may take sections in this direction, or you may cut systematically all the way through. It depends a little bit on how big the specimen is. And this is representing, in this case, DCIS, carcinoma in situ area. And by doing it systematically like this, you can measure the greatest distance on the slide between where the tumor extends, and then you count the number of sections and where they are, so you can estimate how much of an area the tumor reaches over. So that's how we estimate the size. So here are some examples of inking and how that looks in the microscope. So over here you have tumor that's pretty well defined in this case, and this is black ink that is at the edge of the specimen. And this is an example of the margin is clear. There's no tumor in approaching into the margin. It's pretty close. It's probably no more than a millimeter there, but it is clear. In this case, tumor was cut through at the time of surgery, and there's ink on the surface here, and it cuts straight through the tumor. So it's grossly very positive, and it clearly left a fair amount of tumor behind. Now, this is not very common. Usually, margins look different, where you have margin out here, and there's tumor streaming along here. And it can be a little tricky to know how close that margin really is. And when we report it in the report, we make an estimate of how close the closest margin is. So we measure it in millimeters from the edge. But it, in some cases, can be very tricky to know for sure, because when they cut the specimen, they have this heat knife that helps to limit the bleeding during the surgery, but it also cooks the tissue. So you get artifact. You can see how this tissue here looks different than this tissue here. So this is cooking heat artifact. It's coagulated from the hot knife. And that also distorts the cells. So sometimes it's really tricky to know if the tumor cells really are present at the edge. You may have heard about core biopsy, which is a common way to investigate, particularly when there are microcalcifications. And what they do is to use varying gauge corneate, varying from 16, 18 to 12, and the smaller the number, the bigger the core is. So 12 gauge core is really big. And they typically take more than one in order to make sure they don't miss the area. So they take these cores out, and then if they're looking for calcifications, they will actually take this and do an x-ray of the cores when the patient is still there to make sure that the calcifications are contained within the specimen to really document the stuff. Next.
And this is done just to diagnose it, right? It's not
But
going
it's
to
not a
remove all
treatment.
the tumor.
It's not a treatment.
Unlike
It's
some of those other
diagnosis.
surgeries, but this is just, okay, there's cancer there, now we can treat the patient either with more surgery or chemotherapy
Or we don't have to do anything. If you have a really good mammographer who's very good at telling benign from malignant, you may have 30, 40% of patients that really have a cancer at the time of core biopsy. But that's in a center where they're very good at finding it.
So you're saying a lot of them, even with the best,
Even
are
with the
benign
best
because
radiologists,
this-
most core biopsies are going to be benign. And I think this is a very important message for patients who come in for core biopsies. If you have an abnormality on your mammogram and they're seeing calcifications, the chances are still greater that it's going to be benign than that it's going to be malignant. Okay, and this is what the core biopsy would look like in the microscope under low power. You can see sort of it's sort of a long structure. When this happened, this has cancer. You see how disorganized this is? You can't really see individual lobules and little ducts next to it. This is just a whole bunch of gland-like structures in a disorganized pattern.